Hello and welcome to another episode of the Health Notebook. Today we're exploring the area of orthopedics, a speciality within medicine, and we have Dr. Rawoot in the studio. Dr. Rawoot, welcome to the studio.
Thank you for having me.
Can you maybe explain to us what the area of orthopedics is, or can you maybe explain to the viewers?
Well, orthopedic surgery is the surgical specialty that deals with pathology related to bone and joint diseases. So you have elective orthopedic surgery that deals with various conditions involving bones and joints, and then there's also the trauma side of orthopedic surgery. So basically any broken bone falls under orthopedic surgery. Any bone except ribs, that's usually treated by the cardiothoracic surgeons.
Okay, now in terms of the specialities, how many specialities are there within orthopedics?
Well, there's various sub-disciplines in orthopedic surgery. You start off with spinal surgery. That's a bit of a grey area. So you'll either have a spinal orthopedic surgeon that manages spinal problems related to the neck or lower back, but you also have neurosurgeons that manage these conditions as well. So you can either consult a spinal orthopedic surgeon or a neurosurgeon if you have a back problem or a neck problem. Then one of the big subdisciplines is your arthroplasty. That's your joint replacement surgery. That usually refers to hip and knee replacements, but you get various other joints that can be replaced. Your shoulders, those are usually dealt with by your upper limb surgeons. So some orthopedic surgeons specialize in shoulder surgery. Some regard themselves as upper limb surgeons, so they'll deal with shoulder problems, elbow problems, and some even wrist problems.
Now, in terms of your background, now you've mentioned quite a few disciplines. Can you maybe just tell the viewers about yourself as well, where you've come from, what you studied, and what your area of speciality is within, or what your area of interest is within orthopedics as well?
Yeah, sure. Well, I'm 100% Cape Townian. Grew up in Cape Town, went to school here, then did my medicine degree at the University of Cape Town. And at that time, I think we were probably the second year to do community service. So I did my internship and community service at Rawoot Hospital. Thereafter, I wandered off to the UK just to get a bit of outside experience, and that's where I was introduced to orthopedic surgery. I ended up working there in orthopedic surgery and decided there and then that's what I wanted to do. I ended up spending about 4 years there, but I always felt that
I was wanted to become an orthopedic surgeon.
Well, not always, but that my experience there took me in the direction of orthopedic surgery. Having said that, growing up, I always enjoyed DIY work, working with carpentry stuff, and
so it's sort of like a mechanic.
Well, yeah. I mean, some people actually refer to orthopedic surgery as glorified carpentry.
Okay.
And we're basically the carpenters of the surgical fraternity. A lot of the tools we use are carpentry type tools, and the names don't differ that much. So yeah, I think it was kind of fate that I ended up doing orthopedic surgery, but I always felt that I wanted to come back and specialize in orthopedic surgery and not stay in the UK and do it there. So I got back to Cape Town in 2006 and I got a medical officer post in orthopedic surgery. I then had to wait until 2009 before I got a registrar specialist post at Tygerberg Hospital, and I basically did my orthopedic training through the University of Stellenbosch and graduated towards the end of 2013.
Okay, so you have a sort of a broad range of experience. What I've also would like to inform the viewers that you're also involved in some humanitarian activities. I know you mentioned it to me before, so can you maybe just explain to the viewers a little bit about your experience when you went abroad?
Yeah, sure. Well, when I was still an intern at Rawoot Hospital, that was the first time I was introduced to the gift of the givers. And that time they were planning humanitarian aid to Bosnia. That was the time of the Balkan crisis. Unfortunately, because of our tight schedule as an intern, I wasn't allowed to take leave and offer my services as a doctor. But I always felt that one day I would want to contribute to that organization. And after I finished my specialist training, I did a short fellowship in knee surgery. That's my main interest. But just so happened soon after that, word was going around that Gift of the Givers wanted to send a group to Gaza, and I then expressed my interest and made contact with Dr. Imtiaz Suleiman. Unfortunately, the group that went to Gaza was limited to a very small group, so I missed out there. But then, was it now 2015, when the earthquake hit Nepal, I got my first opportunity to go with the Gift of the Givers to Nepal.
Okay, and what was what did you actually do there? Were you on the ground? Were you in the hospital, or what type of service did you provide there?
Well, it was interesting. I don't think I had no idea what to expect. We thought we'd end up setting up field hospitals, but in the end, with Dr. Suleiman's contacts and that, we managed to set up in there's private hospitals in Nepal where the surgeons were being used in the state hospitals. So they had the facilities, we had the expertise to assist. We went with a fairly sizable group of specialists. I think amongst us were 6 orthopedic surgeons. There was general surgeons, maxillofacial surgeons, there was obstetrician and gynecologist, I think pediatric surgeons as well.
Fairly a broad range of
we went there with some good expertise, and in the week that we were there, we were able to do just over 100 operations.
Wow, that's quite a bit.
The bulk of them were orthopedic surgery, because as you can imagine, lots of trauma patients, broken bones, that we were able to.
Okay, now we're speaking about broken bones. You've mentioned broken bones as well. Can you maybe just explain to the viewers, okay, what is the definition between a fracture and a sprain? Just some basic fundamental definitions as well, so that they just understand.
Okay, a lot of people, when you tell them you've got a fracture, they almost sound I don't know. They think there's a difference between a broken bone and a fractured bone, but really it's the same thing. It's just a medical term for a broken bone, as opposed to the orthopedic medical term. So, and when we're dealing with a sprain, usually refers to joints. Or ligament injury. So when you have a sprain, it means there's nothing broken, but the ligaments are not completely torn. So in a way, it's stretched, if you can call it that. Okay,
and then a little bit about the types of fractures. I mean, what type of fracture would you get, like in terms of partial or a complete fracture?
When you're looking at orthopedic trauma, it's a broad field. You get your simple fractures. That's when kids fall onto their forearm, they break a bone. You can classify them as open or closed. Your open fractures would be your fractures that are associated with wounds. So where that's a small wound, a big wound involved with motor vehicle accidents type of thing. Then you get fractures that, as I said, simple as one single break. You also get comminuted or fragmented fractures, so there's multiple
loose
pieces of bone. And then you get your fractures that are involved with the joints, which we call intra-articular fractures. So there's a
broad spectrum
of fractures.
Now, in terms of management, how do you manage a fracture?
That depends on what type of fracture it is. Your simple fractures can be managed by your GPs, can be managed by the doctors in the emergency unit. If it's an undisplaced fracture, in other words, the alignment of the bone is still as it should be, it can be managed in a cast, or in most cases they put you in a splint to allow for swelling to settle and then manage it into a cast. Otherwise, there's surgical management, and we usually operate on fractures if you can't reduce a fracture. So say, for instance, you have 2 broken bones and it's angulated or it's completely off-ended and you can't restore the anatomy with manipulation, and you can't maintain that with a cast, then you would need surgery. And there's certain conditions that if, for instance, you have a fractured hip, we see that quite often in the elderly, the treatment of choice is surgery, because if you let those hip fractures untreated, the patient would lie in bed for up to 3 months, and then they'd be high risk for pressure sores, blood clots or deep vein thrombosis, which can spread up to the lung. So you can have serious complications for conservative management. So surgical management of, for instance, a hip replacement, the benefit is to relieve the pain and to improve that patient's mobility, basically get them up as soon as possible.
Now, in terms of the surgical aspect, can you just inform the viewers what would you make use to actually bring the alignment of the bone together? So just give them some idea of what you actually use to bring the ends of the bone together, or to manipulate the bone so that it actually heals.
Again, it depends on the type of fracture. If you have a child, for instance, a simple fracture of the wrist, the distal radius of the bone, that's usually involved. Under general anesthetic, you can manipulate those fractures into the accepted position, and then you apply a cast and try and maintain that reduction. Sometimes if you have an unstable fracture and you can't maintain that reduction, we resort to putting temporary wires, which we call Kirschner wires, in. Those usually come out after about 4 to 6 weeks once the fracture's healed. Other forms of surgical treatment is what we commonly refer to as open reduction internal fixation. So in other words, you're opening up the fracture, you're reducing it internally, and then you're fixing it, and it's by various techniques, whether you're using plates and screws, whether using intramedullary nails. These are special titanium nails that go in the marrow of the bone, and it's used to splint the bone internally. So there's various, fixation techniques.
Fixation techniques. Now, in terms of the healing process, on average, what is the healing time? I know there's different bones and things like that. So, I mean, on average,
kids tend to heal quicker.
Okay.
So on average, we would say 4 to 6 weeks for a child. In an adult, you're looking on average 6 weeks for upper limb fractures. The lower limb fractures take a bit longer, 6 to 8 weeks. If you're looking at injuries around the foot and ankle, they can take a bit longer. So, for instance, if you fractured your heel bone, that can take up to 12 weeks to heal. Okay. So it all depends on the blood supply to the bone that's affected.
Okay, and what causes a delay in the healing of a bone? Is there any medical conditions?
There's several factors. You look at the local factors, patient factors, and fixation factors. So, for instance, local factors, if you have an open fracture, a fracture that's got a large wound that's contaminated, that's likely to have a higher risk of non-union where it doesn't heal. And then if you look at patient factors, patients, for instance, that smoke have a higher incidence of bone union. And then patient comorbidities. So, for instance, diabetic patients, they're more likely to have wound complications, high risk of wound complications. So you look at the patient factors, and then when it comes to fixing the fracture, also the surgical factors. So how fixing a fracture is not a straightforward thing. There's certain techniques to how we fix it. When we apply the plates and screws, there's a way that we do it to cause compression at the fracture site. So if, for instance, you get proper alignment of the bone fragments, but you don't get compression of the bone edges, then there's a higher risk of non-union. So there is an art to fixing these fractures. And you got to also, it's not just about fixing the bone. You have to realize when you're treating a limb, there's soft tissue surrounding the bone, muscle, tendons, ligaments, and you've got to respect the soft tissue as well. So if you go and devitalize the tissue, there's again going to be a higher risk of infection, higher risk of non-union.
Okay. Now, in terms of, I know the orthopedics works with other healthcare disciplines. So can you just explain who are the important role players in getting the person back to his state that he was before he had the fracture?
Yeah, we work very closely with physiotherapists, and certain orthopedic disciplines also work very closely with occupational therapists. With regards to a physiotherapist, they help with mobilizing the patient post-operatively. So, for instance, if you have a patient who's had surgery to their leg, that patient needs to be mobilized with crutches after the surgery. We take it for granted everyone knows how to use crutches, but again, there's a technique to that, and that's where the physios come in initially after the surgery to get them up and mobile, to get them confident in using their crutches. Thereafter, for instance, if it's a joint there, if we've done surgery to the hip or the knee, you want to get that joint moving, so they would assist with joint mobilization, muscle strengthening. There's various other things. Patients that don't have surgery, we also refer to the physiotherapist, again, for mobilizing the joint, for muscle strengthening, but they also have various treatment modalities that can help to alleviate the pain, and such as ultrasound, TENS, shockwave therapy. There's various, some of the physios do acupuncture as well, so there's various treatment modalities that they can use that assists in the pain control of the patients. And then when it comes to the occupational therapist, for instance, when I do hand surgery, a lot of these patients need splinting afterwards, and the
So what is, to explain to the viewers, what is splinting?
Well, it's basically to splint the hand or the wrist. So depending on what surgery I've done for the hand, sometimes, say for instance, patients had a laceration of a tendon, and we've gone and repaired the tendon or repaired a nerve.
Okay.
You can't just start moving that joint, otherwise the repair can come undone. So for that first 6 weeks or so, that patient would be in a splint to allow for that soft tissue to heal.
So you're sort of immobilizing that particular
that's
area.
correct.
Okay.
And then the occupational therapists, they tend to specialize with the hand surgery, but you find physios that deal with it as well. They'll help with the swelling, to reduce the swelling and to get the joints moving again, and again strengthening as well. Occupational therapists are also very involved with the spinal surgeons. There's a lot of rehab that goes in, and they tend to work closely with the physiotherapist as a multidisciplinary team in terms of managing that patient.
Okay. Now, also, if you can just explain to the viewers in terms of dislocations, what's the definition from the orthopedic side, so that the viewers understand what is dislocations is?
Well, dislocation basically refers to a problem with a joint where normally you have two bones that's involved in a joint, and where if you, for instance, look at your shoulder, it's a type of ball and socket joint, so it's where the ball comes out of the socket. So you can have dislocations associated with fractures, but pure dislocation is where there is no fracture, but you've done damage to the soft tissues around the joint, so the muscles, the ligaments that hold that bones in position at the joint, they all get disrupted during the dislocation.
And then if you could explain, what is the treatment options available for dislocation?
For those patients that can't reduce their dislocations themselves, and you'll find some patients that are able to do that, they dislocate their shoulders and able to pop them back in. But if you're not able to do that and you're in a lot of pain and discomfort, the best is to go to an emergency unit or your GP, depending on where you are. That doctor would then try to reduce or relocate the dislocation, and this is normally done under conscious sedation. So they'll give you something for pain, they'll give you some sedation, and while you're sedated, there's various maneuvers that they can use to try and relocate the dislocated
Okay,
joint.
so once they're done with the relocation, what would be the further treatment? Would it go into a sling, for example, if it's a shoulder?
It depends on what joints involved. Okay. So if the shoulder dislocation is probably the most common dislocations we see. So usually they get placed in a sling, shoulder sling after that, and we keep them in the sling for about 3 weeks. If it's a first-time dislocator, then we start physio after 3 weeks. For recurrent dislocators, you need to go and establish why this patient is dislocating, and that's when they generally get referred to an orthopedic surgeon. We work them up and then try and decide how we would best manage these patients. If, for instance, it's a knee dislocation, now there's a differentiation between a dislocated knee and a dislocated kneecap.
Okay.
Dislocated kneecaps are not so severe. It's similar to your dislocated shoulder that can be popped back with conscious sedation, and then we immobilize them in either a cast or a knee brace after that. Your dislocated dislocated knee is quite a significant injury, and that's associated with high energy injuries like motor vehicle accidents, falling from a height, and that's quite a significant injury because it's not just the ligaments that's disrupted. You can have injury to the nerve and blood vessels, and that usually needs to be treated surgically.
Okay, and you've mentioned that you have a special interest in knee surgery. Can you just elaborate a little bit on that?
Yeah, it just so happened that while I was doing my specialist training at Tygerberg Hospital, I got introduced to Dr. Spike Erasmus in Stellenbosch, and ended up doing a mini fellowship with him after I finished my specialist training. We just gained more experience in knee surgery, and although I currently working as a general orthopedic surgeon, my main interest is in knee surgery, dealing with the arthroscopic treatment of knee problems as well as knee replacement surgery.
Okay, so explain to the viewers what is the arthroscopic aspect of knee surgery. So what do you actually do there so that they can understand?
Okay, so arthroscopic surgery is minimally invasive surgery. It's commonly known as keyhole surgery. When it comes to the knee, we make two little cuts, both less than a centimeter either side of the kneecap. We then insert a telescope or camera inside the knee, can see exactly what's going on and what the possible cause of the problem is. In terms of treatment, we can also do that arthroscopically through those two little holes. Sometimes they have to make an extra hole. The advantage of arthroscopic surgery is that the patient recovers a lot quicker.
So previously they used to open the knee?
That's correct. If you before the advent of arthroscopic surgery, all these knee conditions were treated with open surgery. That meant far bigger incisions, and with that came greater risks of wound complications, and patients took much longer to recover. If we do arthroscopic knee procedures nowadays, the patient generally goes home the same day. In the past, when it was done through open procedures, they'd spend 2-3 days or longer in hospital recovering from that surgery.
Okay, so how do the viewers actually get access to an orthopedic surgeon? I mean, from the public sector and the private sector, can you just explain to them the process? Obviously, you've mentioned that a lot of the fractures can be managed on the local primary care level, but when does the referral take place along the line?
Yeah. Not everyone with a knee problem needs to come to an orthopedic surgeon. One of the first questions you asked me was a sprain. So, for instance, if you've injured your knee, twisted your knee, it could well be a sprain. And these can be managed by your GP. So the first line of treatment would be the use of anti-inflammatories. You can apply a compression bandage, you can apply ice to limit the swelling. You may need crutches sometimes, depending on how severe the symptoms are, but these can all be managed by either your GP or by your casualty doctors. If they feel on your initial assessment that they suspect something that possibly requires surgery, or if conservative treatment is no longer helping, so for instance they've treated you for 2 weeks with the anti-inflammatories, with the rest, with the elevation, with the ice, and there's still no improvement, then they would refer on to an orthopedic surgeon.
Okay, I know we've covered fractures only, but what are the other medical related orthopedic problems that you would cover? For example, back pain and the evaluation of other aspects as well.
Well, I mentioned I do general orthopedic surgery. The one field of orthopedic surgery I don't treat is spinal surgery. Most of the patients that have back pain have mechanical back pain, and again, your first port of call would be to go to the GP or casualty doctor. They would assess you, decide whether you need to be seen by a spinal orthopedic surgeon or neurosurgeon, and then take it from there. Sometimes I get referred these patients, and if I've worked them up and, for instance, there is a problem with a slip disc, for instance, then I would refer on to my colleagues. But I don't do that surgery myself.
Okay, so we've reached the end of the show. Is there any message that you'd like to give the viewers out there in terms of managing a fracture or anything in particular?
Well, if you've injured yourself and you suspect that you may have broken something, and sometimes there's definite signs, deformity, for instance, significant swelling, then go to your GP, go to your local emergency unit. You'll be assessed there. As mentioned, some of these injuries can be managed by those doctors. If they feel that specialist opinion is necessary, they would refer you on to an orthopedic surgeon. When it comes to the elective side of orthopedics, again, if you've seen your GP and your symptoms are not improving, he can then refer on to an orthopedic surgeon for further management.
Okay, so there you have it. Dr. Rawoot has given us a broad overview of the area of orthopedics within medicine. Hopefully we'll be following up a patient in the near future. So thank you for watching. Stay tuned for another episode, same time, same place next week.